Hello everyone, it's great to see so many of you online. So welcome to the webinar, I'm a prostitute, so can you check me? Exploring sex work stigma in healthcare. My name is Rachel McLean and I will be your webinar moderator. This webinar is being offered by the Canadian Public Health Association as part of a webinar series that is being hosted over the next several months focused on the reduction of stigma associated with sexually transmitted and bloodborne infections. More information on this webinar series can be found on CPHA's website. You can also connect with me directly if you'd like further information or if you're interested in presenting a webinar as part of this series. So before we begin, just a quick note to let you know that today's session will be recorded and made available on CPHA's website in the coming weeks. So throughout the course of this webinar today, you can use the chat box for any questions, and we'll have some time at the end of today's session for Cecilia and Dan to answer your questions. So today we are going to hear from both Dr. Cecilia Benoit and Dan Reist. Dr. Cecilia Benoit is a professor in the Department of Sociology and a scientist at the Centre for Addictions Research of BC. Cecilia's research employs mixed methods to investigate the health of vulnerable groups, including Aboriginal women in Vancouver's downtown east side, young people confronting health stigmas linked to obesity and asthma, street-involved youth in transition to adulthood, workers in lower prestige service occupations, pregnant women dealing with substance use, and adults in the sex industry. Dan Reist is an assistant director with the Centre for Addictions Research of BC at the University of Victoria and principal knowledge user on 2 CIHR-funded projects under the leadership of Dr. Benoit. Dan leads a team that focuses on communicating current evidence in a way that supports the evolution of effective policy and practice. So with that, I will turn it over to Dr. Cecilia Benoit and Dan Reist.
Good morning. It's
hello, everybody. Thank you. Sorry, Dan. Dan's going to begin, and then I will pick up a little later.
Okay, thanks, Cecilia. So welcome, everyone, and it is indeed good to see so many folks interested in this topic. And just to let you know that the research that we'll be presenting today grows out of a CIHR-funded team grant that was really made up of 5 different projects, research projects, and we'll get into that in just a moment. But if we move the slide to the next slide, just to kind of remind us of what it is we're hoping to achieve in our webinar today, is we want to look particularly at this issue of stigma, and in particular in the context of healthcare services provided to sex workers in Canada. And so we'll be exploring, that's really what we're exploring throughout. And as part of that, we're particularly interested in this issue of the sex workers disclosing their sex work to healthcare providers and what kind of responses they've experienced and reasons why they would or would not disclose. And using that to jump off to thinking about, and this is really the most important piece of the webinar in many respects, is to identify actions that we can take at the health service delivery level that would reduce the negative implications of disclosure for sex workers and allow them to have better access to healthcare services.
Sorry, Dan, can I just interrupt for a quick second?
Yep.
We're having some folks who are having a hard time hearing you. Could you just try speaking either a little louder or perhaps moving the microphone closer?
Okay, I will try to speak more clearly. Is that working better?
It's certainly louder on my end. Thanks.
Okay. So if we look at the next slide, just a little bit of information about the research project itself. Thank you. So as I mentioned earlier, that it was really a set of 5 studies, one looking at sex workers in particular, one looking at or working, identifying their intimate partners, one clients, one managers of sexual services in the industry, and one about regulators and providers. And we used a lot of common questions across all of those so that we could make some interesting comparisons. And in addition to that, we collected sample data from 6 different centers across the country, metropolitan centers. And those were in Victoria, in Calgary, in Fort McMurray, although the sample from Fort McMurray is relatively small, in Kitchener, Waterloo, Cambridge, in Montreal, and in St. John's, Newfoundland. And just a word about who participated in the study. The one that we're reporting on today is really the sex worker study, and so we define sex work as the exchange of sexual services for money, and we included in the sample only adults, those 19 years and older who were legally able to work in Canada and who received money in exchange for sexual services. And as you can see on the slide, we had 218 participants in the sex worker study. If we move on to the next slide, some of the unique features about this particular research that I think important to highlight rather quickly this morning is that we had clear operational definitions, and there was a lot of work done in the early stage of the project trying to hammer out what those common definitions would be that we would use across the studies. And so I've already mentioned the definition for sex work, or sex workers, and sex work. But we also then had standardized questions that applied across those so that we could make those interesting comparisons, and questions that would also allow us to compare the results of these studies with CCHS and GSS data. So using and adapting as closely as possible questions from common surveys. We looked at key variables and open-ended questions so that we could really understand what the experience was that sex workers were having, not just using those kind of closed questions that we could use for comparison purposes, but really trying to delve deeper into each of these areas. I've mentioned the multi-city piece and the diverse research teams already. And just a few of the results that came out of the study before we get into the sort of main direction of the webinar today. Not surprisingly, I suppose, if you stop to think about it, that people who work in the sex industry in Canada are not so different in terms of diversity and background and circumstances as Canadians in general. And I think that's a point that's really worth pausing and reflecting on for a moment, that the diversity within the industry kind of reflects the Canadian norm. Compared to other Canadians, however, sex workers are marginalized and on most of the social determinants that we would use to measure marginalization, with the exception of personal income, in which case in personal income they are higher than many other occupations and workers with similar backgrounds. In terms of work context, we find that the context matters, that when workers are able to advertise in different media, they're able to have greater control over their work environment and negotiate things like services with the clients, condom use, etc. We find that usually there is not conflict when workers have that ability to work. They have a greater sense of autonomy there, and clients accept that on the whole. workers who delivered services in their own homes and in environments where they had some control reported better relationships and safer environments. So those were all really important findings in a general sense. However, participants did report high levels of stigma and discrimination, and it's really to that we want to focus on in our webinar today. So I'm going to turn it over to Cecilia to begin that with looking at some of the issues around stigma.
Thank you, Dan. So the next slide, please. Yeah, so what I'm going to do in this first part is talk a little bit about how to conceptualize stigma in relationship to sex work, and then we'll talk about some of the findings from our study. So conceptualizing sex work, we're talking about 3 types of taint. Could you please go to the next one? So in the literature, there's discussion about physical taint, about social taint, and about moral taint. And sex workers in our study are dealing with all 3 types of this kind of stigmatization. So next slide. So when we think about public health and physical taint, one we're really talking here is about the taint associated with body fluids and body parts. So in the sex work literature, you often see the role of sexual transmitted infection discourse in shaping how we think about what health professionals think about sex workers. Could you hit the slide, please, again? No, go back one. Sorry, I think there's something that didn't come up on the first slide. Anyway, it's okay. We're missing something there, but that's fine. So we see here in this particular depiction here, there's a relationship between almost femininity, sex, prostitutes, and syphilis and gonorrhea. And we see this in the literature. A lot of the sex work literature talks about the STI and sex work is almost simultaneously in the discussion. Next one, please. We also see in the literature a discussion about kind of a social taint, or how sex work is tainted because of its association with others. In particular, clients who are often depicted as evil or as degenerates and so on, and we see this kind of shaming that's often associated with clients. And also in the literature we see drug use and prostitution or sex work being collapsed together. So this kind of a taint that's associated with sex work in relationship to others who are also tainted. Next one, please. And finally, in the literature we see this kind of moral taint that's associated with how the public values and lawmakers and so on see sex work. So in the recent discussion in Canada in the last year and a half, we had, with the debate over Bill C-36, we have quite strong kind of moral taint associated with sex work, and also that people who are involved in it are morally corrupt, and there's this kind of a degrading association with it. And if we look at our new law, the Protection of Communities and Exploitation Persons Act, it's been said, expressed right in the law, that an inherently exploitative form of discrimination against women and children. So sex workers who are involved in sex work and willingly stay in the industry then become seen as deviant and unworthy by the moral majority. Next one, please. So as a little experiment, we thought we'd get your perception of sex work stigma. So I've taken 4 of the 12 items from the Perceived Evaluation and Discrimination Scale by Lincoln Phelan, and I wanted to have a poll to see how you would perceive sex work in relationship to stigma. So Rachel's going to put these up. So the first question, most people would accept a sex worker as a teacher of young children in a public school, and you can go to, you have 6 choices. So what would you rate this poll as? You're all filling it out. And once you're finished your rating, I will give you the rate that came from our study. So that's a fair number of people. So in our study, sex workers said they either strongly disagreed or disagreed with that particular act. So quite similar, actually, than your answer. This next one. The second one is most people think less of a person who's working in the sex industry. So what's your answer to this particular? Do you strongly disagree or strongly agree? You see that you're answering quite similar to the sex workers in our study as well. So you either said agree or strongly agree, and sex workers as well. So their range was in between agree or strongly agree. So most people think less of a person. That's getting at that kind of moral stigma. Next one, please. And the third one we put up here is most people in my community would treat a sex worker just as they would treat anyone. So how would you rate this particular, how would you answer this particular question? You know, strongly disagree or strongly agree? And in my community is just in the place in which where we live. So in the general community in which you live. It could be a city or a town. So we get a little bit more variation on this one. And in regard in our study, sex workers themselves all either said strongly disagree or disagree. So you have you're answering tend to disagree a little bit more than the sex workers in which we interviewed. And then the last one, please. Most young women or young men would be reluctant to date a person who works in the sex industry. Do you strongly disagree or strongly agree? And again, you're answering you're either tend to agree or strongly agree. And for the sex workers, it was usually agree or strongly agree. So quite similar in your answers compared to what the people in our study, which were 218 people who are working in the industry, answered. So that's very, very interesting. So I think what we're seeing here is a very strong perception of stigma related to sex work in our country. Great, Rachel. Thank you very much. Next slide, please. So now I wanted to show you some results, comparative results that use the same measure across some other studies. So you see our study is at the bottom of this figure. So out of a scale of 5 sex workers overall perceived sex work, using not just the 4 items I showed, but the 12 items, is 4.8, so quite high. And in a study by Lincoln Phelan by people with mental health conditions, it was 4.15. Legally blind people, it's a study that myself and some other colleagues conducted, it was 3.4. And then for sex workers, service providers of sex workers, another study that I was involved in, it's 3.29. So we see here that there is a range in the perception of stigma, but sex workers themselves perceive a very high level of stigma associated with their work. Thank you. Next slide. But that's not the full story. If we actually look at some of our other results, we ask sex workers how they deal with this perceived stigma. And do they internalize it? Do they try to mediate it or resist it? And you'll see here from this particular slide that internalization was only for a minority of the people in who we interviewed. So about 20% say they internalize the stigma, and then that often leads to self-blame and feeling very low self-worth. But for majority, they engaged in other tactics to deal with the stigma. Mediation, dealing with more selective disclosure, disclosing only to some people and not to others. Reframing, it was about half of them said this, and which means that saying that actually my work is not degrading. It's actually I'm in a profession, or I'm doing work that's worthy, and so kind of reframing the kind of activities they were involved in, and saying that they were legitimate like other kinds of activities. And then actually resistance. So sex workers resisting the stigma, turning it back on people who stigmatize, and pointing out their double standards, and saying that they were not going to accept this. So what this shows is that sex workers have a lot of agency in relationship to dealing with stigma, and they don't just accept the views of the dominant majority. They actually work with those and try to improve the situation for themselves, at least at the individual level. So we're going to talk about this resistance and this agency when we talk about the dilemma of disclosing sex work in healthcare. But before I do so, I'll allow for some questions. Does anyone have anything they want to ask right now, or should we just move on? Yeah, someone's bringing up a point about intersectionality, and I think we'll thinking about a labor rights perspective. That's going to come up a little bit later, so keep that in mind as we move forward. So Dan, I'm going to pass it over to you now. You'll look at the next section.
Okay, thank you, Cecilia, for.
And sorry, Dan, if I could just ask you to once again speak into the mic. We did have some audio issues again, so if you could just speak into the mic and perhaps a little bit louder. Thanks.
Okay, so thanks, Cecilia. Let's move to our next section then, and start to think about the actual issue around. So we've talked about stigma in terms of the healthcare setting. We also wanted to look at the issue of healthcare itself and the needs for healthcare. And so if you look at this slide, you will notice that in terms of general health, the sex workers actually rate their health as lower than the average Canadians rate their health at a fairly significant level. And so we could argue that, or it's pretty obvious that they do have healthcare needs at least as high or at a greater level than your average Canadian. Now, when you look over to mental health, you find the picture gets even more extreme, that there's a significant, a major difference in terms of how they rate their mental health as much lower than that rated by average Canadians. So again, a real need for healthcare services, both to meet the issues of physical health, but also to meet the issues of mental health. And then when we asked sex workers about their experience of being conscious of a healthcare need, but not having that need met, 40% of them reported that that was true of them, whereas only 15% of Canadians would say that. And so you have almost 3 times as many health or sex workers at a rate of 3 times as much reporting that they have unmet healthcare needs. And so that's a significant challenge for the healthcare service providers to think about how is it that we can address that fact that there is such a high level of unmet healthcare needs, and what are the reasons that that exists. So that's really the question that we want to pose right now is, if you were a sex worker, what do you think would be some of the factors contributing to your unmet healthcare needs? And so I'd be interested just for us to speculate for a moment, what would be those factors that would be particularly contributing to that high level of unmet healthcare needs? Anyone wanting to suggest some of those? You might want to just type some of the ideas into the chat box. While people are typing, it's really an important exercise for us to try to empathize by putting ourselves in positions and thinking about what it would be like in that situation. So, suggestions that we have are lack of community acceptance, fear of judgment by providers, racism in the case of where there might be a race issue, lack of doctors taking on new patients, so just a systemic problem in the system. And so you see that many of you are naming some of the factors that you imagine would be the case. And so if we actually look at the reasons given by sex workers, this is only a small sample of all of the reasons that, of course, they cited. And what we find is that not shown on this slide are a lot of reasons that are common to Canadians to other Canadians as well, that where they're not very different in terms of a lot of the factors that contribute to unmet healthcare needs. But where we do find significant differences are on the ones that are on the slide. And so if you look at this one here, very major difference, almost 30% of healthcare workers said that they didn't get around to it or didn't bother. Now that begs a question. I mean, of course, in the general Canadian population results, it was 8.6%. And so there's a very large difference. And so what does it mean when a sex worker says they didn't get around to it or didn't bother? I mean, that I think is open for us to think about. Too busy, again, there was a significant difference. And so what's going on there that contributes to that? Transportation is a much more significant issue as far as reported by sex workers compared to the Canadian population in general. And then there's this one here, dislike of doctors or afraid. And that goes right at the core of, well, what's going on here in the healthcare system that such a high percentage of sex workers would report that. we also asked separately, and we don't have comparative data to the general population, and that's why it's not on the slide here, but we also asked the question of concern about being judged. And over 20% of sex workers reported that that was a major factor in why they had unmet healthcare needs, because they had a concern about being judged, and which probably ties in with the question about doctors and being afraid. Now, when we explored with sex workers a little more about this issue and whether they disclosed or not to healthcare workers, what we found out was that sex workers, that 80% of sex workers brought up the issue of disclosure in the conversation. So there were a number of folks who didn't talk about the issue at all, but 80% of our sample did. And when we look at that 80% or 79%, about 2/3 of those had disclosed, and about 1/3, just over 1/3, had not disclosed. And when we did try to understand the difference between those two groups, like what would have led to disclosure, what might have led to them not disclosing, there aren't a lot of differences. There's no differences around race or Aboriginal identity or high school completion, income, age, sexual orientation, whether or not they had grown up in government care, and so on. So on most of those issues, there were no clear distinctions between the two groups. On one, however, fewer men sex workers disclosed compared to women or transgendered people, and so that may suggest that there's even higher levels of stigma or other reasons for fear when it comes to male sex workers. There were a few other areas where there was some difference, although not statistically significant. Things like born in Canada versus foreign born. So 66% born in Canada would have disclosed, only 44 born outside of Canada. And so there were a few differences, but really most of them not very significant except for the gender question. Now, when we started to explore with people the reasons they did not disclose, of course, we've already seen some of those, but three things really emerge as the key factors here. The first one being this issue of judgment. That 23% of the sample, of the total sample, reported that at least once in their lifetime they had experienced discrimination in a medical setting. So this isn't just discrimination anywhere, but in a healthcare setting, 23%, so almost a quarter of the entire sample had experienced that. And so this fear of judgment is at least reasonably well founded. It's not just an internalization of the stigma. It's well founded on experience. Two other arguments or reasons were often given. One is that the worker didn't feel that it was any of the business of the healthcare provider, and so they chose not to provide or to disclose. And then the other one was some concerns around confidentiality. And you can see some of the quotes that some of the things that sex workers told us with respect to these factors. When we looked at, or when we explored with those who had disclosed and asked them about some of the costs that they had experienced, or when they discussed those costs, the things that came forward were, again, judgment, that experience of being judged, of discriminated against, stigma, and inappropriate care. and particularly in inappropriate care, it was really the attitude, the assumption of a kind of master status attitude that sex workers made reference to, that when they disclosed, the providers had these kinds of superiority, communicated a kind of superiority status situation, and that was disrespectful. On the other hand, the vast majority, or a large majority at least, of those who had disclosed had also reported that they had received benefits from disclosing, that there were many things that they got because of that. And in particular, they reported that their relationship with the healthcare providers improved, that there was a greater level of trust, that the providers were non-judgmental, and some of the fear of judgment was able to be dissipated. They also spoke of the fact that they got better care, targeted care, so they were able to receive care to reduce or prevent work-related health risks, including life-saving treatments that may not have been administered without them having disclosed their sex work status. And they also felt that they were able to get into relationships of continuity of care, that having disclosed to a service provider, building a relationship with that service provider led to greater continuity of care. And so those were some of the key benefits that they perceive and derive from disclosing. So the real dilemma that I think we face as a system is to recognize that although most who have disclosed experience benefits, there is a substantial minority who have never disclosed because of largely fear of discrimination or fear of being judged. And there is also a minority of those who did disclose who experienced significant costs as opposed to the benefits. So what is it that we can do as service providers and as system planners within healthcare to ensure that more people are willing to disclose and have a positive experience when they do? I'd be very interested in suggestions that you have that might come forward to resolve that dilemma. And again, just encourage you to type in some of those and to observe what your peers across the country are suggesting in the chat box. So any specific suggestions on how we can improve the situation for sex workers in terms of their willingness to disclose so that they can have their health needs met by the system? Okay, well, I'm going to challenge you to continue to think about that, and I'm going to turn it over to Cecilia to move us on to the next section of our discussion.
Great. Thanks, Dan. I see some people are making comments, education for primary health care providers, creating outreach services like shifts in Calgary and so on. So we'll some of those will come up as well as I move to our last section. So we're going to talk a little bit about what sex workers themselves see as friendly services for themselves. So, sorry. So what we're thinking about here is what do sex worker friendly services look like, and what do sex workers want from their healthcare providers? So these are issues that are, I think, really, really important and are not easy to develop. When we were, sorry, why it keeps jumping back and forth. Just a second. Rachel, can you help me, please? So I'm sorry about that. In a recent report by the World Health Organization, they suggested that healthcare services should be made available, accessible, and acceptable to sex workers based on the principles of avoidance of stigma, non-discrimination, and the right to health. So these are three really important and interrelated components: availability, accessibility, and acceptability. And in our analysis of the open-ended question with sex workers, asking them about what they wanted in healthcare, all of these components came out either in the quantitative or in the qualitative findings. In regard to availability and acceptability, these really are at the system and patient level. So these issues came out in particular in the quantitative data on unmet healthcare needs that.
Sorry, Cecilia, we're having trouble hearing you.
Okay, sorry. Can you hear me now?
Yeah, that's much better. Thanks.
Sorry. So in regard to the first two components, availability and acceptability, the sex workers spoke about these or reported on these in the quantitative data on unmet healthcare needs that we showed a little earlier. So cost of care, lack of transportation came out, and the cost of care in particular for mental health services was important. Also, sex workers talked about or mentioned didn't get around to it, too busy. These are more patient level components, and we need to unpack them, why they reported those. So those came out in our quantitative data. In our qualitative data, the acceptability was the main component. So this is a kind of provider-based component or aspect that we wanted to draw your attention to. So when we did the qualitative analysis of acceptability, again, what sex workers were talking about was the approachability or non-judgmental approach of providers. So they were looking for providers who were compassionate or at least non-judgmental, and this is they noted that this should be part of their standard practice. They also were looking for appropriate and comprehensive care. So again, if they were they were seeking sexual health services, they want to have the tests that would help prevent risk and so on in regard to their work. And they especially, or third component was confidentiality. So they didn't want their status as a worker to be shared with other people. This should be something that's kept in confidence with them. So this acceptability at the provider level was really, really important for the workers in our example. So just to summarize then, technical care was not a major concern for sex workers. We do live in a country where public health services, many of them are covered within the healthcare system. So in the qualitative, the technical concern, technical aspects of care were not, didn't emerge as very important. It was really the attitudes of providers and their relationship with sex workers that came out as the dominant themes in the analysis. So we're nearing the end of our presentation here, and we wanted to you to give us some practical steps that you would recommend to help deal with some of these concerns. So and I see that you're commenting already, peer-led services would be very helpful, and help fund workers themselves to develop and hire workers for services, and also community-based service delivery and community-based organizations in workplaces for peers, such as the work that Stella does. So we see that you have some really good ideas about what to do in regard to dealing with these concerns. And so I think in our study we see at the individual level, sex workers have a lot of agency, and they really are trying to deal with some of the issues they face in healthcare. But there are avenues within the public healthcare system to actually take steps to reduce the stigma and to improve the care that's provided to sex workers.
So Cecilia, one of the things that I think I see coming up in the comments, and maybe it's kind of implied more than exact, is that maybe we can make links between some of these peer organizations and the healthcare system itself, so that they can provide some training and support around attitudes and non-judgmental approaches, which I think would be a really interesting piece to take on, to help the peer groups help train some of the professionals.
Yes, Dan, that's a really good point. We had a small pilot study here in Victoria where CIHR gave us some funding to work with Peers Resource Society and in regard to linking health service delivery with sex workers themselves, and so sex workers could give feedback to health providers about what it was like to feel stigmatized in healthcare, and also how those providers might be able to change some of their attitudes. So that would be, I think that's a very, very good way, linking the health services in the community with sex worker organizations and other outreach agencies and sex workers themselves, so that there can be multiple feedback loops.
There's also a technical question here about our data comparisons to the 2003 CCSH data. And just for the point there is, we used 2003 often because that's where we had comparison questions that were relevant to our study. And so I don't know if Cecilia, you want to say any more about that, but that's being raised here.
Yes, in the earlier, the 2003, they had questions about healthcare, in particular about the feeling fear of doctor and also the transportation. And so these were items that we were interested in having sex workers report on as well. Some of those items were dropped. Those items were dropped in the later CCSH. So we decided to use the earlier one because we're interested in how sex workers would view unmet healthcare needs. Also, I noticed there was discussion earlier on about survival sex work. We didn't use that term in our study, but I can report that 29% of the 218 people we interviewed had soul sex before the age of 19, and what's really interesting, they're more disadvantaged than those who had started to sell sex after age 19, especially in regard to whether they were ever in government care. So half of the people who sold sex earlier than age 19 had lived in government care in their early life. Well, this was less than 25% of the other group. And then also I noticed there was a question about gender and gender breakdown. So 77% identified as women in our study, 17 as men, and 6% of other genders. So so we do have some gender diversity, but there's not a direct match between your experiences in healthcare and your gender or as Dan pointed, in regard to Indigenous status and so on. These statuses and the variations that in people's backgrounds do matter. But what was so interesting, I think, about our study, that we expected there would be an intersection of stigmas in healthcare seeking and in regarding the problem of disclosure. But that didn't really come out. The main master status, if you like, was sex work. A little bit mention of drug use and of alternative genders, but it was not the predominant focus of people we interviewed. It was more to do with the work that they were involved in that carried the most fear of being stigmatized. Anti-oppression training seems to also come out. There has been some really good work done in the mental health area, so trying to reduce stigma for mental health concerns, and they have used a lot of the strategies that you're suggesting here in the chat box. And I think it's very difficult to be able to become aware of how you're treating other people when you're providing care. And the more that those people are involved in showing you that that your attitudes are stigmatizing, then the better. So a lot of the work that's done in the area of mental health is, even through humor, but also through training, direct training, has been very helpful in trying to reduce the stigma associated with mental health. And I think that could be useful for our sex workers as well.
Yeah, one of the other themes that came through in the research that I don't think we touched on today, but was that when sex workers did disclose their sex work status to healthcare providers, that that even that act of disclosure was helpful in reducing the stigma or some of the attitudes of the providers. And so as providers get to know people who are sex workers, there's a stigma reduction. So that in itself, that the act of disclosure itself is a tactic to reducing stigma at times.
Yeah, and I also noted that Laura's mentioning that health authorities need to provide funding for peer-led organizations. I think that's crucial. We really do need different types of healthcare available within our communities. And there's a debate even within our within our study about whether if they should be sex worker-led health services versus just general. And it seems to me that what sex workers mainly want are general health services, but where they are open, trustworthy, and non-stigmatizing. But those services could definitely be organized and led by peer organizations. So it's interesting discussion for sure. I think our time is just about up. I think the one other thing I wanted to end with is that in order for the stigma around sex work to really be reduced, I think we need to also work at the level of punitive laws. So in Canada right now we have a punitive law that criminalizes buying completely, and also a lot of the advertising. There's a lot of work needs to be done at the level of the political system. So moving towards the decriminalized models, and such as they have in New Zealand, where they actually have a public health and harm reduction, public health, health prevention framework around sex work. I think that would really help move reduce the stigma. We've seen research coming out from New Zealand that shows that stigma continues to exist in New Zealand, but not at the same level as has been noted in our own country. So we can't forget that we have to keep the lens as well on the level of the law reform at the political level, and if we really want to reduce the stigma and violence associated with it, and the stigmatizing attitudes and practices. So I just wanted to turn. Sorry, go ahead, Dan.
Just one other piece there that's come up in the comments again is this reference to municipalities, and that was really something we looked at in our work, is that while we want to change laws at those federal levels and higher levels of government, but municipalities have a huge influence here too, both in terms of the acting out on the laws as well as in influencing the senior levels of government. So we shouldn't forget municipalities as a key player in that.
Yes, that's definitely the case. So I wanted to let you know that we have been doing some publishing on this work. The first article that's will be on the website Understanding Sex Work any day. It's just supposed to be coming online this week. It gets at the multiple reasons why sex workers ever became involved in sex work, and you get there at the kind of structural concerns in a society, and also the agency deciding to initially sell sex work. So that's an interesting kind of nuance to some of the discussion that we often see in the media. We also have published in the Canadian Journal of Public Health our data on the unmet healthcare needs that we presented today. So, and that's the comparison with the general population. And finally, we have an article that looks at sex workers' views on the police in Canada, and the lack of confidence in the police creates what sex workers call a blue ceiling in regard to their safety. So that's another paper which you may find interesting. The latter two papers are already uploaded on Understanding Sex Work website, and the first one will be there soon, and we continue to publish on this topic, and we will be publishing looking on the dilemma of disclosure as well when we fine-tune our presentation. Thank you.